Biologics have revolutionised the treatment of chronic rhinosinusitis with nasal polyps in recent years. The drugs in widespread use globally are Omalizumab, Mepolizumab and Dupilumab. But two new large-scale trials on novel molecules, that's Dupilumab and Tezepelumab, have now been published, yielding fascinating results and important implications for patients. This is EUFOREA News, broadcasting from London. Hello and welcome to EUFOREA News. I'm Dr. David Bull. The use of biologics in the treatment of CRSWMP in clinical practice has implemented a paradigm shift in outcomes for patients. Given that CRSWMP usually has an endotype characterized by type 2 inflammation, and by understanding and targeting the inflammatory cascade associated with it, treatment has been revolutionized. The majority of biologics target cytokines and mediators such as IL-4, IL-13, IL-5 and IgE. Over the last 5 years, 3 biologics have been registered and reimbursed for CRSWMP, or nasal polyp syndrome, in most countries. They are Omalizumab, Mepolizumab and Dupilumab. They have proven efficacy, good safety profiles and superiority over revision surgery for severe uncontrolled sinus disease. Using non-surgical treatment options reduces the need for patients to undergo revision surgery and gives the clinician more options to achieve remission in CRSWMP. Recently, there have been 2 large trials on novel molecules which have been published. The Lancet paper looked at the efficacy and safety of twice-yearly Dupilumab in CRSWMP, whilst the New England Journal of Medicine focused on Tezepelumab in adults with CRSWMP. Well, to tell us more about these 2 promising novel molecules for CRSWMP is Professor Joseph Hahn. He is Professor in Otorhinolaryngology, Head and Neck Surgery at Eastern Virginia Medical School in the United States. He's also Vice Chair of Clinical Affairs and Administration and Chief of the Division of Allergy. He's also past President of the American Rhinologic Society. Joseph, really good to talk to you once again. Let's start, if we can, with this Lancet paper. This is looking at the efficacy and safety of twice-per-year Dupilumab in CRSWMP, the Anchor 1 and Anchor 2 trials. Do you want to start by just talking us through that?
Yes, thank you, David, for the question. So we were able to present the Anchor 1 and Anchor 2 data most recently at one of our scientific meetings. There we were able to talk about the role of this phase 3 study evaluating the use of Dupilumab for patients with nasal polyp. And what's kind of novel about the study was that most of the phase 3 studies have been really focusing on like European and the US or North America patients, but this study was one of the first studies that actually had a worldwide population. And the reason why that's important is because we know that nasal polyps do vary based on the region of the world. And so this is what the study did. The study looked at, to see if it was effective looking at nasal polyp and symptoms of nasal congestion, which really is a good measure of how the nasal polyps are doing.
So just looking at the trial, Dupilumab being the first ultra-long-acting biologic engineered with enhanced IL-5 binding affinity, high potency and an extended half-life. Is that the most striking finding of the trial itself? Is it the fact that it's just twice a year that you have to give it?
Yeah, so there were several things about the study that was striking. Yes, having a Q6-month dosing is very important, and there's certainly an unmet need there. For example, there was a market survey that asked patients, how do you like to get your medication? And there are three main routes. One is through the mouth, one is through topically, like for the nasal polyp, it would be a spray through the nose. Another one is subcutaneous injection. Of the three modes of medication delivery, the oral medication is by far the most favorable one, the sub-Q being the least favorable one. The only time that the sub-Q injection or medication delivery outperformed or became more favorable than the oral administration was when patients were getting the injections every 6 months.
So I mean, that's quite something, isn't it? If you're giving the injection just once every 6 months, compliance is going to be really good. Also, if patients see improved symptomatology, then obviously they're going to look on this very favorably.
That's absolutely right. So patients would prefer to get injections every 6 months rather than taking a pill every day. And I think personally for me, that even makes sense. And when I've polled my patients and asked similar question, they all agreed that they would prefer the injection if it was every 6 months.
So let's now look at the New England Journal of Medicine. The Dupilumab being used here in adults with severe chronic rhinosinusitis with nasal polyps. What did this study show?
So this study also showed, similar to Dupilumab, that it was very effective in treating nasal polyps and symptoms of congestion. Similar to the Anchor 1 and Anchor 2 study, the Wavepoint study, which is the Tezepelumab study, the phase 3 Tezepelumab study for nasal polyp, it also was a worldwide study. What was striking about the Wavepoint data was both the studies showed that there was a quick onset of improvement. There was statistical improvement not only in the primary endpoint, but also in the secondary endpoint. But the difference in the endpoints between the treatment group and the placebo group was a little bit bigger. And so, for example, one of the secondary endpoints that was measured in every phase 3 study for nasal polyp using a biologic was SNOT-22. When you look at the SNOT-22, the change from baseline for most biologic studies have usually been around in the range of 30. Tezepelumab is the first biologic that broke that barrier and was able to have a change of 45 points from baseline. So that's huge. Another secondary endpoint that was really interesting was the need or the use of surgery for patients who felt like they weren't doing well during the clinical study. And that was the need for surgery. This is the only study that only had one patient that needed or required the use of surgery to kind of salvage from the biologic study. So that was pretty impressive.
And of course, Tezepelumab acts on the inflammatory cascade much higher up, and obviously that is significant.
Yes, that's right. And so if you look at Dupilumab and the other biologics, they specifically target the different cytokines and inflammatory markers that are a little bit lower in the inflammatory cascade. Tezepelumab is the first biologic that targets the epithelial, one of the three epithelial alarmin. This specifically targets the TSLP.
So obviously we're seeing more and more biologics coming on stream. What's your sense going forward about the role that biologics will play going forward, obviously as cost comes down, and also, I suppose in many ways, your sense of excitement at the future?
Yeah. And you're absolutely right. We're going to see more biologics coming down the road. There's actually one smaller phase 2 study that got published in Lancet. They just completed their phase 3 study called Stapy-Bulkart. It is a biologic that targets the IL-4 receptor, similar to Dupilumab, but it targets a different epitope. And what we're seeing is that it works similar to that of Dupilumab, but it doesn't seem to increase the blood eosinophils as we see in Dupilumab. Now, there are more clinical studies that are ongoing. So right now I'm going to another scientific meeting where we're talking about bivalent monoclonal antibodies or bivalent molecules, large molecules that can also target these type 2 diseases. So that's one of the directions that I see that where we're going. And, it doesn't seem to stop. The number of large molecules that are coming out are increasing. Now, how that is going to impact our treatment for nasal polyp, it's unclear. If I had to predict, I would say it's not going to change too much of how we currently treat our typical nasal polyp patient. But for the more severe patients, I think these large molecule treatments will probably have an earlier intervention to try to decrease any irreversible changes that we see in our patients with nasal polyp.
Joseph, it's always such a pleasure to talk to you. Thank you very much for your time. That's Professor Joseph Han.
All right, thank you for the invitation to be on the show. Thank you.
Well, let's now talk to Professor Jivian Li. She is Associate Professor of Rhinology and Endoscopic Skull-Base Surgery, Head and Neck Surgery at the University of California and the David Geffen School of Medicine in Los Angeles in the United States. Professor, thank you very much indeed for joining me. First of all, can I ask you for your thoughts and really your interpretation of the data on Dupilumab in the context of existing biologics?
Well, I think one of the most promising and attractive aspects of this particular biologic is its long-acting nature. It's really the first one that we have that would be once every 6 week, or I believe 26-week dosing, which is really revolutionary in terms of just patient convenience and compliance. Now, if we look at just a deep dive into the data itself, they did reach their primary endpoints where they're able to show a significant reduction in nasal polyp size, with the 52-week mark, as well as improvement in nasal obstruction. I think the one aspect where I would be less enthusiastic is that it didn't reach it to the similar degree as some of the other biologics that we currently have available. So for instance, Dupilumab, right, we could see an improvement about, I think it was -2, for the polyp score, this was around, -0.7 or so. So it wasn't a full point on the nasal endoscopy score. Similar with the symptoms, it wasn't a full point. And then if we look at the secondary endpoints, they also didn't reach statistical significance in many of those outcome measures. And probably the most prominent would be the SNOT-22, which is our validated instrument for looking at subjective symptoms in our nasal polyp, or really all of our sinus patients. And they didn't reach the MCID, or the minimum clinically important difference. I believe it was in their integrated analysis, it was -8, and usually we want to see at least a -9. And in some of the other biologics that we currently have that are available and FDA approved, they reached the MCID pretty readily. I think it was almost -19 or 20, with Dupilumab, -16 with Mepolizumab. So I think when I look at it in a big picture, I am impressed with the fact that it's much longer term dosing in terms of the schedule. And again, they did reach their primary endpoints, but there were some aspects of it where they did not reach the same clinical significance or statistical significance even as some of the other biologics. The other issue, of course, is when we look at one of the secondary endpoints in terms of smell, right? That's a big symptom that a lot of our nasal polyp patients suffer from. They didn't use an objective measure that I could find. They didn't use the UPSIT score, which is what we typically use to measure olfaction. And our nasal polyp patients that we use in some of the other phase 3 trials, they use subjective measuring, and that also had some, equivocal improvement compared to some of the other biologics that we currently have.
Okay, well, let's turn our attention now to Tezepelumab, shall we? What did you think of Tezepelumab in the context of biologics, certainly now, and also, I suppose, going forward into the future as well?
So with Tezepelumab, it reminded me very much of Dupilumab, in terms of the efficacy. And the dosing's the same. Well, it's a little bit longer. It's once a month, whereas the Dupilumab is once every 2 weeks. But in terms of the data, again, they did reach their primary endpoints. They're able to show a reduction in their nasal polyp score as well as nasal congestion. And this time, the nasal polyp score was reduced to the same degree as, for instance, the Liberty trials, like with Dupilumab, where it was, minus 2, whereas, as I said, with the previous biologic with that we just discussed, it was like negative 0.7. So I think definitely they reached the same degree of primary endpoint as the Dupilumab and some of the other biologics that we have. And then similarly, I was really impressed with the improvement in the SNOT-22 scores. Not only did they reach the MCID, it was probably the best, I think, when I looked at all of the other phase 3 trials. I think they were able to achieve an improvement of minus 27. And if we think about the MCID being minus 9, I mean, that's 3 times the MCID. Whereas if you compare it, with the anchor study, it was just, minus 8 with the integrated analysis. So that there's no question that the efficacy was much more pronounced with this particular biologic. And also when they measured olfaction, they did use, UPSIT scores, and they're able to show that there was statistically significant improvement in their patients that were treated with this biologic versus the placebo. And they're also able to demonstrate that the improvement in smell happened probably within the first 2 doses. So I think the data for the tezepelumab is very impressive, which isn't too surprising because it acts, much more upstream than some of the other biologics that we currently have.
I mean, clearly this area of medicine is moving incredibly quickly, and obviously that means that we will have the option or choice of maybe 5 biologics for CRSWMP in the future. That's going to be much more difficult in terms of making that decision of which one to use. How would you go about making that decision? And also, which biomarkers do you think would be useful to base that choice on?
I mean, that's a great question. And I think it's a good problem to have that we have so many biologics that are emerging that are going to be part of our treatment armamentarium for our nasal polyp patients. I think as more and more, get introduced, into the market and show their efficacy, then we'll really have to kind of do a pretty deep dive in terms of deciding which one is best. Now, with our current group, I think we have to look and see what their comorbidities are. Some of these biologics, for instance, like Dupilumab, they are FDA approved for other diseases, other type 2 inflammatory diseases, right? Like atopic dermatitis, eosinophilic esophagitis. So for instance, if a patient, comes with those comorbidities, it'll be easier to decide which biologic to use based on their comorbidity profile. Now, in terms of the biomarkers, and I think this is also a challenge, at least in the United States, we don't have a lot that are readily available in all the clinical laboratories. So for instance, probably the easiest for us to measure would be, for instance, like a CBC with DIF to measure the serum eosinophil count, get a serum IgE. So I do that routinely in all of my patients. I know in Europe there are other biomarkers that are available and smears that you can do as part of point of care endotyping, but they're actually not readily available in the US. So if we just have that data, then what I typically do is I do look at the serum eosinophil level because it's markedly elevated, and I know there's been some debate on what the cutoff of the eosinophil level should be. If it's 800, 1,000, 1,500, then I would not do Dupilumab because I would be worried about eosinophilic pneumonia. And in that sense, it would kind of push me towards one of the anti-IL-5 biologics. Mepolizumab is the only one that we currently have available. If someone has like comorbid allergic asthma, for instance, or elevated serum IgE, maybe something over 200, then I would consider Omalizumab. So those are the different biomarkers that we have. Now, if these other 2 that we just discussed, which have not been FDA approved yet, come onto the horizon, then there'll be another discussion about where these 2 would fit in particular. And then I would look at other things. Assuming efficacy is the same, then I would look at convenience and dosing schedule. And this is always a shared decision-making process with the patient as well. We kind of look at not only the biomarkers or comorbid conditions, but also the ease of convenience, whether they want to continue to give themselves shots and what dosing intervals will be most convenient for their particular quality of life.
Clearly, we are starting to see all of these drugs coming online. Cost is always going to be a big problem in terms of getting these drugs onto formularies around the world. Different countries will then dictate which drugs can be used for each of those country-specific populations. How, though, do you see the future of biological care for CRSWMP? Do you see a state where actually the biologics will completely replace sinus surgery?
It's interesting. We always have this as constant debate. And I think honestly, I mean, chronic rhinosinusitis in general, with or without polyps, traditionally we've always treated it as a combination of surgery and medical therapy, that the two complement each other. And I think the only reason why this has become a binary discussion, whether it's biologics or surgery, is because of the cost. And to be honest, at least clinically, in my own experience, the patients that I have that have had surgery and then have biologics or some combination of both, whether the biologics are given before or after surgery, like we similarly do with our steroid rinses, those patients do amazing. You know, as you see with the biologics data, they're never able to get the polyp score down to 0, right? It's always either improvement of 1 or 2. But after you do surgery, the polyp score is 0. Right? It's the main issue is just trying to control it medically so it doesn't recur. And so I could see a role for the biologics complementing surgery and the two going hand in hand to really maximize the quality of life for our patients. So even like the first biologic we discussed, the Dupilumab. So even if maybe their endpoints may not be as strong in terms of their clinical or statistical significance, because their dosing is so great, I could see a role for it, for instance, as a maintenance biologic, where somebody has surgery and maybe they're on the steroid rinses, but they need some extra help. Then you give them a shot every 6 months. So I'm hoping at least it doesn't continue to be this sort of mutually exclusive binary discussion, that this ends up being another aspect of our treatment armamentarium. And together it will be a collaborative effort where the two modalities actually complement each other to get the best possible outcome for our patients. Because alone, they may not be as great, but together, we'll really be able to achieve that highest level of quality of life for our nasal polyp patients.
It's so good to talk to you. Thank you so much for your time. That's Professor Jivian Lee.
Thank you so much.
Well, really fascinating stuff. 2 more biologics to consider in the treatment of CRSWMP as and when they come online. Many thanks to my guests, to Professor Joseph Han and Professor Jivian Lee. Now, you can find more information about EUFOREA. You can also register for the EUFOREA educational events on the euphorea.eu website, where you can also sign up to receive the latest news via email. We're also on social media on YouTube, X, LinkedIn, Spotify, Instagram, and Facebook. Please do follow us. But until next time, goodbye.